Hello guys, now in this video let's discuss about placental abnormalities. We have already seen how normal placenta develops and what are the hormones which are getting produced from the placenta. Now in this video let's see some abnormal types of placentas. To begin with, see in this image there is this placenta where the umbilical cord is getting attached to the one margin or one end of the placenta. Actually the umbilical cord, it should attach in the center of the placenta, but in this type of placenta the umbilical cord is getting attached to one end. So such type of placenta is known as a battledore placenta, where there is marginal insertion of the umbilical cord is seen, and such kind of battledore placenta will lead to retained placenta, and that further causes secondary postpartum hemorrhage. We know retained products of conception can lead to secondary postpartum hemorrhage. Now see here in this image you can see this is one placenta. Okay, this is one big placenta, and also there is one small accessory lobe of the placenta. Now here these two placental lobes are connected with the blood vessels. Okay, so such a type of placenta is known as Succenturiate placenta. There is one big lobe and one small extra accessory lobe. These both lobes are connected by the blood vessels. Very important point. For example, if these two lobes are not connected by blood vessels, means okay, there is a type of placenta where there are two lobes, one big lobe and one small lobe, but there is no vascular connection between them. It is known as Placenta Spuria. Okay, what exactly is Placenta Spuria, guys? Placenta Spuria is exactly same like Succenturiate placenta, but there is no blood vessel connection between the two lobes. Again I am repeating, Succenturiate placenta means small extra accessory lobe is present and blood vessels are connecting the main lobe with the accessory lobe, and such kind of Succenturiate placenta is also an important risk factor for the secondary postpartum hemorrhage. Okay, important point. Now see here in this image you can see that there is one lobe of placenta. This is one lobe of placenta, and there is one more lobe of placenta, but important point is that both the lobes are all equal size. So this type of abnormal placenta is known as placenta bilobata or placenta duplex. Okay, now two equal size placental lobes will be there, and both the lobes are again connected with the blood vessels, and this can also be a risk factor for secondary postpartum hemorrhage. Why? Because there is a risk of retained placenta, and that leads to secondary postpartum hemorrhage. Now guys, what you are seeing here, see here the type of abnormal placenta is known as circumvallate placenta. Okay, take my word. See, in circumvallate placenta and circummarginate placenta, see there are these two types of abnormal placentas which are known as circumvallate, this current one. Okay, whatever you are seeing is the circumvallate, and there is circummarginate. The main problem with these two types of placentas is the chorionic plate, that is the fetal side of the placenta. Okay, see in the placenta there are two sides, maternal side, fetal side. Maternal side of placenta is known as basal plate, and fetal side of placenta is known as chorionic plate. The main problem with the circumvallate and circummarginate placentas is that the chorionic plate, see the chorionic plate is smaller in size when compared to the basal plate. Okay, so this is the main problem. See, other than this, like you don't need to remember much. Chorionic plate is less in comparison to basal plate. So how to differentiate circumvallate placenta with circummarginate placenta? In both the conditions, chorionic plate is lesser than the basal plate. But if I am talking about circumvallate placenta, means see there will be a central depression. Okay, there is this central depression. If there is this central depression, that is a circumvallate placenta. But with circummarginate placenta, there is no central depression. And also, see in circumvallate placenta, the edges, the placental edges, here you will be having this thick, okay, this thick fold. Okay, this thick fold which is nothing but an amnion. See, there is this thick amniotic fold will be seen. Okay, so in circumvallate placenta, the placental edge is thickened like a wall and it is rolled up. But with the circummarginate placenta, there is no central depression. There is no thickening. Okay, there is no thickening of the placental edge. So this placenta, what you are seeing, is a circummarginate placenta. Here also, chorionic plate is smaller than basal plate, same as circumvallate placenta. See, the circummarginate is similar to circumvallate, but what is the difference? The difference is the placental edge is not thickened and there is no central depression. This is circummarginate type. Okay. Now, after this, let's see the complications because of circummarginate and circumvallate, both. Okay, I'm not talking about just circummarginate. What are the complications because of circummarginate as well as circumvallate placentas? There is a risk of antepartum hemorrhage. There is a risk of abruption, preterm labor, and intrauterine death. These are the complications or risks seen with both circummarginate as well as circumvallate. Now, here in this image, what you can see is the umbilical cord, okay, the vessels in the umbilical cord, they are getting inserted onto the membranes, okay. This is the amniotic membrane. See, the umbilical vessels, they are getting inserted onto the membranes. Later, these vessels are getting entered into the placenta. So, this is known as velamentous insertion of the cord. So, what exactly is velamentous insertion of the cord? Vessels are going to be inserted onto the membranes first. Now, these vessels are more prone to rupture. Now, these blood vessels contain blood or not? Yes, definitely these vessels having blood. Which blood? Maternal blood or fetal blood? See, these are fetal blood vessels, right? So, they can lead to, see, rupture of these blood vessels can lead to antepartum hemorrhage, and this type of hemorrhage is known as Vasa Previa. Okay, what exactly is Vasa Previa? Vasa Previa is seen due to rupture of the fetal blood vessels. Why these fetal blood vessels are getting inserted onto the fetal membranes? They are at a more prone of rupture. So, rupture of these vessels will lead to fetal hemorrhage, which is having a highest mortality. Okay, very high mortality will be seen. Okay, the blood loss is fetal in nature, not maternal in nature. See, why I am saying so specific? Antepartum hemorrhage can be because of placenta previa, it can be because of abruptio placenta, it can be because of Vasa Previa. But in placenta previa, in abruptio placenta, the hemorrhage is maternal in origin. But here in Vasa Previa, the blood lost is fetal in origin. So there is a lot of risk for mortality in the fetus, not mother, in the fetus. So what is the investigation of choice? It is the color Doppler. Okay, say if you want to diagnose, okay, even before rupture, if you want to diagnose Vasa Previa, if you want to rule out Vasa Previa present or not, you can do the color Doppler. But once if there is hemorrhage, there is a female with antepartum hemorrhage. Now, how to know that the bleeding is maternal or fetal? Imagine that there is a female who is going to present to your clinic. Now, she is 33 weeks of period of gestation. Now, she is having 33 weeks of period of gestation and she is bleeding. Now, this bleeding, antepartum bleeding, may be because of placenta previa, abruptio placenta, or it might be because, might be because of Vasa Previa. How to differentiate a maternal bleeding from fetal bleeding? There is a test. Okay, there is a test called as Singer's, okay, Singer's alkali denaturation test or OPT test. What exactly is this OPT test? Guys, OPT test is a qualitative test. Okay, it's a qualitative test. What exactly we are going to do? See, now she is bleeding. Now she is bleeding. You just collect that blood. Now you want to know this bleeding is maternal or fetal. Now what you can do is you can add this alkalis, sodium hydroxide. When you add this sodium hydroxide to the bleeding, remember, if it is a fetal bleeding, okay, if it is fetal hemorrhage, you have added the alkali, nothing will happen. Why? Because see, fetal blood, fetal RBC will have hemoglobin F. Okay, fetal blood or fetal RBC will have hemoglobin F, which is resistant to alkali denaturation or acid denaturation. You put alkali or you put acid, hemoglobin F is not going to be denatured. So color of the blood is not going to change. But if it is maternal blood, imagine that there is this placenta previa and now she is bleeding. This is maternal blood. Now, the moment you add sodium hydroxide, potassium hydroxide, maternal blood have hemoglobin A, and this hemoglobin A is not resistant to alkalis. Hemoglobin A is sensitive to alkalis, so hemoglobin A will be denatured and the color of the blood is going to be changed. So if it is a maternal hemoglobin means there is change in the blood color. The blood will become almost colorless. So what I am trying to put into your mind is there is this qualitative test which will differentiate maternal hemoglobin from the fetal hemoglobin. The test is APT test or Singer's alkali denaturation test, where we are putting sodium hydroxide or potassium hydroxide to the blood. Adding sodium hydroxide to the blood, if there is color change, that is maternal hemorrhage. There is no change in the blood color, it is fetal hemorrhage, because fetal hemoglobin is resistant to alkalic denaturation. Okay. Now, even in this image, you can clearly see that the umbilical cord vessels, these vessels are going to be inserted onto the membranes. Okay. Now, the rupture of membranes can lead to rupture of blood vessels that further lead to fetal hemorrhage. Okay. Now, let's discuss about a clinical case on Vasa previa. Guys, please concentrate in the question. A female was admitted to labor ward. All her vitals are stable. Artificial rupture of membranes is performed for augmentation of labor. Okay. Now, after performing augmentation or by artificial rupture of membranes, there is a severe bleeding per vaginum. After artificial rupture of membranes, there is severe bleeding. Why? Why? Because see, the blood vessels are present on the membranes. You have ruptured the membranes. Rupturing of membranes will damage the velamentous insertion of the blood vessels. Okay, these inserted blood vessels will be damaged and that causes fetal hemorrhage. Now, the hemorrhage is fetal in origin. What we have to do? The fetus will be in distress. Fetal heart rate is now 90 beats per minute. Fetal scalp pH is 7.0. What is the appropriate step? The appropriate step is going to be immediate C-section. This is fetal hemorrhage. We shouldn't do any normal vaginal delivery, tocolysis. No. Immediate C-section is the best. Okay, this is the case of Vasa previa. Now, after this, let's see this image. See, is this velamentous insertion of blood vessels? No, this is not velamentous insertion of blood vessels. Blood vessels are not going to be, okay, inserted onto the membranes. Membranes are not going to have the blood vessels. What exactly is happening here? See, the umbilical cord is going to divide into lot of branches before insertion into the placenta. Okay, before getting entered into the placenta, the umbilical cord is forked. This is known as Furcate placenta. What exactly is Furcate placenta? Here, the umbilical cord divides into many branches before entering the placenta, but there is no insertion onto membranes. Okay, very important MCQ. After this, let's talk about a few important points about the umbilical cord. Now, umbilical cord, what is the normal length, guys? Normal length will be 40 to 70 centimeters. Approximately, the length will be 55 centimeters. Now, what exactly is the short cord? If the umbilical cord length, if it is less than 32 centimeters, it should be called as the short cord. And what exactly is the long cord? If the length of the umbilical cord, if it is more than 100 centimeters, it is known as long cord. Now, what are the contents in the umbilical cord? We all know that umbilical cord contains two umbilical arteries which carry deoxygenated blood and one umbilical vein which carries oxygenated blood. Important point is actually two umbilical arteries will be there, two umbilical veins will also be there. But what happens? Right umbilical vein is going to disappear. MCQ. Okay, umbilical arteries will be staying. Left umbilical vein will be staying, but right umbilical vein will disappear. So very important point is right umbilical vein will disappear. Two arteries will be there and vein will be there in the umbilical cord. Now, what is the connective tissue which is present in the umbilical cord? The connective tissue is known as Wharton's jelly. And what exactly are folds of Hoboken? Folds of Hoboken are nothing but these, like spiral shaped coiling. Okay, this is the coiling of the umbilical cord. These coils are known as the folds of Hoboken. So folds of Hoboken are seen in umbilical cord. True. Now, if they ask you what is the most common vascular anomaly of the cord, Most common vascular anomaly is single umbilical artery. Instead of two arteries, there is only one artery. That's the most common cord anomaly. Now, after this, let's talk about some morbid adherent placentas. What exactly is this morbid adherent placenta? See, placenta is morbidly adherent, pathologically adherent. Now, let's see some basic points. What exactly is this Nitterback's membrane? Guys, see, for example, if this is uterus, let me tell you some basic point. If this is uterus, this is the embryo, blastocyst. See, this blastocyst should undergo implantation. We know, okay, blastocyst, with the help of syncytiotrophoblasts, it should undergo implantation into the decidua. See, the blastocyst should not go too deep into the wall of the uterus. It should not go into the myometrium or it should not go into the perimetrium. So, there is a limiting membrane. That limiting membrane is known as the Nitterback's membrane. This Nitterback's membrane doesn't allow the embryo or blastocyst to go deep into the wall of the uterus. If it is going too deep into the wall of the uterus, placenta will be forming in the wall of the uterus. That causes morbid adherent placenta. So, if placenta is forming, if placental villi, they are reaching the myometrium, do you think that this placenta will be easily separated after delivery? No. So, what exactly is this Nitterback's membrane and what is its clinical importance? Nitterback's membrane limits the invasion of blastocyst into the wall of the uterus. Now, absence of this Nitterback's membrane will lead to morbid adherent placentas. Very important point. Absence of this membrane will cause pathologically adherent placentas. Now, the placental villi, they will go into the myometrium and they can go even up to perimetrium. See here in this image. Now, this placenta, the placenta, see, it is till here decidua. Okay, placenta is present in the normal decidua. That is something normal. But see here, this is accreta, placenta accreta. The placenta is reaching to the superficial myometrium. Not good. Okay, placenta is now, the placental villi are going till the superficial myometrium. If I am talking about placenta increta, the placental villi, they are almost going into the myometrium, and in percreta, placenta percreta, please consider these placental villi are even coming to the serosa or perimetrium. So, if someone asks you, what are the three different types? Okay, what are the three different types of a placenta? Morbid adherent placentas, they are placenta accreta, increta and percreta. Okay, now see, chorionic villi can reach up to the myometrium and even to the perimetrium. Now, what are the types of morbid adherent placentas? You know it, accreta, increta and percreta. In accreta, placental villi reaches up to the superficial myometrium. In increta, placental villi reaches deep into the myometrium, and in placenta percreta, villi reaches up to perimetrium. Now, what are the risk factors? Very, very important point. Actually, this kind of morbid adherent placentas is seen in a condition known as placenta previa. See, if there is placenta previa, we know that placenta previa will cause antepartum hemorrhage. That's a total different thing. But this kind of low-lying placentas, this kind of placenta previas, sometimes they will end up as morbid adherent placentas. So, placenta in the lower uterine section, they will go too deep into the myometrium. Their placental villi can sometimes even reach up to the perimetrium. That can cause morbid adherent placentas. After delivery of the baby, these placentas are not going to come up. Why? Because they are penetrated deep into the wall of the uterus. So, what are the risk factors? Now, current placenta previa. Right now, there is placenta previa. This placenta previa may be having a morbid adherency to the uterine wall. Okay, it may be morbidly adherent to the uterine wall. Previous history of C-section, curettage or myomectomy can also be a risk factors. Now, how you are going to do the diagnosis? See, antepartum you can do diagnosis with the ultrasonography. See, you can do ultrasonography where you can see heterogeneous appearance of the placenta. Okay, the placenta is going to appear heterogeneously. You can see that, like, the placenta is going into the myometrium or even up to the perimetrium. But for looking inside the organs, okay, organ sections, the gold standard is going to be MRI. MRI is gold standard. but investigation of choice usually is the ultrasonography, where you will see the heterogeneous appearance of the placenta. Now, how we are going to do the management of such condition? Management is, see, the morbid adherent placenta is diagnosed after delivery. Okay, you have it's like, everything is normal, you just deliver the baby. Now you are trying to take out the placenta, but placenta is not coming. Now you came to a conclusion that this placenta is a morbid adherent placenta. Okay, before you don't know, before doing delivery, you don't know that there is this morbidly adherent placenta. After delivery, you came to know that this placenta is not coming. Morbid adherent placenta is there. Now what to do? Hysterectomy. Okay, what you can do is only hysterectomy. What if you have already diagnosed morbid adherent placenta even before delivery? Okay, even before delivery. Now she came to the clinic at 32 weeks or 33 weeks. Now just by doing ultrasonography or MRI, you came to a conclusion that there is morbid adherent placenta. What you can do is do C-section and deliver the baby. After delivering the baby, you can go with the hysterectomy. Okay, so if it is diagnosed before delivery, deliver the baby by C-section followed by hysterectomy. So if there is morbid adherent placenta, means you have to go with the hysterectomy only. Either if you have diagnosed earlier or either if you have diagnosed after delivery, the only option is hysterectomy. Okay, now guys, we have completed the abnormal placentas. Now let me discuss a small topic, which is a uterine inversion. Actually, this is not the topic which I should be discussing here, but I don't find any other place to discuss it. Now let me discuss a small topic of uterine inversion. Guys, what exactly is a uterine inversion? After delivering the baby, the uterus may be turning inside out. Okay, the uterus is turning inside out. This is not the uterine prolapse. This is uterine inversion. The uterus is inverted. Okay, so inside out turning of the uterus. So because of this inside out turning of the uterus, the main problem is going to be shock. Initially, the shock is going to be neurogenic shock. Okay, suddenly the baby will fall. There will be a lot of pain. See, the shock which is seen initially, it's a neurogenic shock. Later, the shock will be hemorrhagic shock. Okay, such inverted uterus cannot contract properly. When if it's not contracting properly, there is this postpartum hemorrhage happening after the delivery of the baby. So important point is, initially the shock is neurogenic, but later on the shock is because of loss of blood, that is hemorrhagic. If they ask you what is the most common cause of death in a patient with uterine inversion, in a patient with uterine inversion, the most common cause of death is hemorrhagic shock. Okay, now important word, please concentrate. Patient presents with the shock. A female is going to present with shock immediately after delivery. Actually, after delivery, if there is shock, most common cause is postpartum hemorrhage. Okay, postpartum hemorrhage is causing shock. That's okay. But if they use this word, patient present with shock immediately after delivery, degree of shock is out of proportion to the amount of bleeding. Okay, see, there is less bleeding, but the degree of shock is more. Initially, the shock is because of neurogenic shock. Okay, so degree of shock is in out of proportion to the amount of bleeding. Bleeding is less, but so severe shock is there. This is because of a uterine inversion, which is usually seen after the delivery of the baby. Now, what are the causes? See, the causes include, the most common cause will be mismanaged third stage of labor. In third stage of labor, actually what you should do, you should be doing controlled traction of the cord. Okay, so in the active management of third stage of labor, you should be doing controlled traction of the cord. If you do inadvertent traction of the cord, that can cause inside out turning of the uterus. So, mismanaged third stage of labor can lead to uterine inversion. Atonic uterus, if the uterus is not contracting after delivering the baby. Now, this is a floppy uterus. Such a floppy uterus can simply involute. Such floppy uterus can easily invert down. Okay, yes, possible. If there is a fundal placenta, yes, see, this is the uterus and here is the placenta, fundal placenta. Now, such a fundal placenta, like, the cord is going to be something like this. Whenever you do traction of the cord, there will be there will be inside out turning of the fundus. So fundal placenta is a risk factor, and morbid adherent placenta. Now morbid adherent placenta simply we have already seen that placenta accreta, percreta, increta. Now placenta was too tightly attached with the uterine wall. See, this is a uterine wall. Placenta was tightly adherent to the uterine wall. Now, without knowing what you are doing, you are trying to give the traction on the cord. Whenever you do such things, there will be inversion of the uterus. So, what are the causes of uterine inversion, guys? Mismanaged third stage of labor, atonic uterus, morbid adherent placenta, fundal placenta, they are all the risk factors. Okay, now let's see what is the management of a uterine inversion. Now uterus is inside out. Now what you can do is manual replacement. Please concentrate in this image. See, this inside out turned uterus with the hands was replaced back in its place. This is a manual replacement, which is also known as Johnson's maneuver. So Johnson's maneuver is used to manage uterine inversion. With also the hydrostatic pressure, by pumping saline, by pumping forceful saline, you can put back the uterus in its place. That is known as hydrostatic 𝐒𝐿𝐵𝐼n's method. So hydrostatic 𝐒𝐿𝐵𝐼n's method is used, or it's employed for managing uterine inversion. Okay, see, these are not surgical things. There are certain surgical methods, for the uterine inversion, that is Huntington's method, Halshian method. Okay, Huntington's method and Halshian methods are the ones which can be used for the management of uterine inversion. Now let's see a few important single liner kind of questions. Woman after delivery goes into shock. After delivery goes into shock. That is postpartum shock. Most common cause is postpartum hemorrhage. Postpartum hemorrhage is the most common cause of shock after delivery. But if they use the word most common cause of shock, immediate shock after delivery. See, woman after delivery goes into immediate shock, and the degree of shock is out of proportion to the amount of bleeding. The most common cause is going to be uterine inversion. But if they ask you, woman after delivery goes into unexplained shock. Now she is in shock, but there is no bleeding. It's not a hemorrhagic shock. There is no uterine inversion. Then the most common cause is going to be amniotic fluid embolism. Okay, so amniotic fluid embolism is the most common cause of unexplained shock. Okay, guys, I have discussed all the important points about the placental abnormalities. Also, we have discussed a small important topic, that is the uterine inversion. Hope the video is helpful. Thank you.